Welcome to the Rad-Onc Smart Review Head and Neck Cancer series.
Today we are diving into Foundation C, net levels, and spaces that change volumes. And this is really the anatomical bedrock upon which every single treatment decision in head and neck oncology rests.
We're starting this series with anatomy for a reason. There's just no way around it. In head and neck oncology, anatomy truly is destiny.
Yes.
If you miss the primary lymphatic drainage pathways, you're advertising a high probability of a geometric recurrence. But, and this is just as critical, if you treat too much, if you include basins that are not at risk, you are guaranteed to introduce avoidable, life-altering toxicity.
Absolutely. The tension between tumor control and quality of life is never more apparent than in neck coverage. The goal here is ultimate efficiency and precision.
And this stuff is not just academic.
Not at all. This is high yield for your written boards because they love the logic behind nodal drainage. And it is, frankly, survival material for oral boards, where missing a key nodal basin on a contouring case.
Oh, like the retroformiagals.
Exactly. Or unnecessarily including one, like level 1B, can be a huge liability.
So our mission today is to build a practical three-dimensional map. We're not trying to memorize, arbitrary coordinates or just draw neat rectangular boxes.
Wow.
We're building a mental grid, the map you can lay over every cross-sectional image, every CT scan you scroll for the rest of your career. And this map is all based on predictable cancer spread.
To anchor this whole, pretty complex discussion, let's start with a classic clinical scenario. This case will tie all of these anatomy and staging decisions together into one critical management moment.
Okay, let's frame the patient. So you're seeing a 55-year-old male, and importantly, he has no significant smoking history, which is already giving us a clue about the underlying biology here.
Right.
He presents with a chief complaint of a painless right neck mass. On examination, there's a 3-centimeter exophytic mass visually confirmed on the right tonsil. Palpably, there's a mobile, approximately 2-centimeter node in the right upper neck, situated just below the angle of the mandible. Flexible laryngoscopy confirms the primary mass is confined entirely to the tonsillar fossa.
And that's key. No midline involvement.
No obvious soft palate midline involvement and no base of tongue extension across the midline. Imaging confirms a T2 primary and an enlarged pathological right level 2 node. A tonsil biopsy confirms the diagnosis. Squamous cell carcinoma, P16 positive.
So the central question for you as the treating oncologist is always the same. Given the specific anatomy and favorable biology, what is the definitive radiation plan? Specifically, what are we doing with our nodal volumes and our systemic management?
Okay, so let me give you the 60-second board script exactly as you deliver it in an oral board setting before we spend the next 30 minutes justifying every single decision in this summary.
Let's hear it.
This is a patient with human papillomavirus, or HPV, associated oropharyngeal squamous cell carcinoma of the right tonsil, clinical T2, clinical N1, M0, per the American Joint Committee on Cancer, or AJCC 8th edition, stage 1. Workup includes a complete head and neck exam with fiber optic evaluation, cross-sectional imaging of the neck with contrast, dental assessment, baseline swallowing evaluation, and positron emission tomography CT or PET-CT to complete staging and evaluate for distant disease. Definitive management is curative intent radiation therapy to the primary and involved neck with elective coverage of at-risk nodal basins. Concurrent systemic therapy is not automatic in stage 1 HPV-positive disease. It is generally reserved for higher risk features, for example, advanced T-stage, multiple or bulky nodal disease, or the presence of extranodal extension, or ENE. If treated definitively, gross disease typically receives a curative dose, with elective nodal dose delivered to the uninvolved at-risk neck. For volumes, I would target the primary tonsil site and the involved right level 2 node with appropriate margins, and electively treat the ipsilateral level 2, 3, and 4 neck with selective consideration of ipsilateral lateral retropharyngeal nodes, depending on specific risk factors such as posterior pharyngeal wall involvement or base of tongue extension toward the midline.
Okay.
Counseling focuses heavily on managing acute toxicities like mucositis and taste change, but critically, managing long-term toxicities such as xerostomia, dysphagia, and dental risks, emphasizing that smart nodal selection is the primary tool we have to reduce long-term quality of life detriments.
That is a highly polished template. So now let's reverse engineer it. We need to unpack the anatomical and pathological rationale that justifies every single line of that summary.
Right.
And we have to start with the core concept. Why were these neck levels even created in the first place?
I think the biggest leap for residents is realizing these levels are not arbitrary. We often talk about them as if they were just invented in a vacuum.
Exactly. They are codified failure patterns. That's our core analogy here. These boundaries represent a vocabulary built by surgeons, like Dr. Shah and others, based on meticulous surgical dissections and recurrence maps from decades ago.
So they literally mapped out where the cancer went.
They literally mapped out where the cancer went when the primary lymphatic basin was involved. When we contour level 3, we're not just drawing a rectangle, we are treating the predictable highway of lymphatic spread after it has passed through level 2. We're treating probability.
And the corollary, as you mentioned, is that we spare the unnecessary detours. If the cancer doesn't typically spread there, we keep the gope out. And that's how we manage long-term toxicity, particularly shoulder and salivary function.
So how do we build that mental grid that works on a CT scan? The key is to memorize landmarks you can actually see, regardless of the patient's orientation or size. We need to identify structures that define those vertical and anterior-posterior borders.
We're looking for the bony scaffolding and the muscular borders, so think mandible, the anterior and posterior bellies of the digastric muscles, the hyoid bone, which is a major vertical separator, the cricoid cartilage, another crucial vertical separator, the sternocleidomastoid muscle, or SCM,
Right.
and of course the vascular bundle, the carotids, and the internal jugular vein, or IJV, and then the longus colon prevertebral muscles. These structures are your transition points on every single axial slice.
Perfect. So let's unpack the levels by association, starting high and working our way down that jugular chain.
Let's do it. We begin with level 1, the oral cavity levels.
Okay, so this region is defined by the mandible above and the digastric muscles below. It's the high anterior drainage system.
First up, level 1A, the submental level.
This is the midline region, defined between the anterior bellies of the digastric muscles. This area drains the very front of the mouth, the chin, the tip of the lower lip, the anterior floor of the mouth, or the tip of the oral tongue.
And crucially, for our HPV tonsil case, this is not a routine elective level.
Not at all. If you have an oropharynx primary that is well lateralized, level 1A is out. We only include it if the disease is extremely anterior, involving the anterior floor of mouth or extending way past the tonsil toward the midline of the tongue.
Then we have level 1B, the submandibular level. This is the space laterally contained between the inner mandible and the digastric muscle. It's where the submandibular salivary gland and its nodes live.
And your high-yield clinical shortcut for level 1B is that it's the oral cavity level. It drains the majority of the oral tongue, the lateral floor of the mouth, the buccal mucosa. The key distinction here, which saves patients from chronic misery, is that tonsil and larynx primaries generally do not warrant level 1B coverage unless there's some unusual extension into the oral cavity itself.
Okay, let me challenge that for a second. I've seen some older textbooks that suggest a much broader sweep of the upper neck for tonsil. Why is sparing level 1B so critical for the patient's long-term quality of life?
That's a great question, and it gets right to the heart of toxicity. The submandibular gland sits smack in the middle of level 1B. And while the parotids provide most of the watery, serous saliva, the submandibular glands provide the majority of the mucus lubricating saliva. If you unnecessarily dose level 1B, you destroy this crucial mucus component.
And that leads to that thick, sticky saliva.
Exactly, which patients often describe as much worse than just general dryness. Sparing 1B is a purposeful maneuver to preserve functional swallowing and speaking.
That makes that anatomical boundary, the digastric muscle, separating 1B from 2 absolutely vital on a CT scan.
Precisely. And once we move below the digastric, we hit the central highway. Moving superiorly, we enter the first and most critical landing zone for upper tract cancers, especially the OPC we're discussing. Level 2, the upper jugular.
So level 2 sits around the upper IJV and the upper spinal accessory nerve region. Vertically, it runs from the upper cervical landmark region, about C1, down to the caudal edge of the hyoid bone.
Yeah.
This is nearly always in play for upper pharyngeal disease tonsil, base of tongue, nasopharynx.
And here is where the major technical nuance of dose sparing comes in. The split between level 2A versus 2B.
Okay. In the contour atlases, this split is commonly defined by the posterior edge of the IJV, the internal jugular vein. So 2A is the anterior or medial part, adjacent to the vessel.
And 2B is the portion that is posterior to the IJV.
Right.
And this split is not just academic, it's tactical. Level 2B often encompasses the superior aspect of the spinal accessory nerve, cranial nerve 11, or CNXI, as it travels toward the SCM and the trapezius.
So why do we dedicate so much discussion to 2B? Is it purely for toxicity sparing?
It's a profound dose-sparing opportunity. In highly selected, favorable, low-risk scenarios, say a very small, well-lateralized T1 oral cavity primary with a clinically N0 neck, you might argue for excluding 2B to protect CNXI and reduce posterior neck dose, minimizing that shoulder dysfunction risk.
But in a case like artist T2N1 tonsil, it's non-negotiable.
Absolutely. The moment you introduce meaningful nodal burden, especially an involved level 2 node, the probability of microscopic disease extending into 2P is just too high. It's non-negotiable in nasopharynx and any higher burden upper neck disease. You have to accept the increased risk of shoulder toxicity to ensure oncologic control.
So sparing 2B is a privilege.
It's a privilege earned by low-risk disease, not a default setting.
That is a powerful distinction. Okay, excellent. So stepping down, using the hyoid as our superior boundary, we get to level 3, the middle jugular.
Level 3 is the direct caudal continuation of level 2. The boundary is defined by the caudal edge of the hyoid down to the caudal edge of the cricoid cartilage.
Okay.
And since it's the next predictable step-down basin, level 3 is included in virtually all comprehensive neck plans when the upper neck is involved. It's an essential highway, a direct continuation of the level 2 drainage.
And further down, using the cricoid as our upper boundary, we find level 4, the lower jugular.
Yep, this is the region below level 3, extending from the cricoid down to just above the sternoclavicular region where the thoracic inlet starts. Conceptually, this is the lower neck jugular chain running down to the supraclavicular fossa.
So level 4 inclusion, this is a subject of some debate in early oropharynx cases. When does level 4 become absolutely mandatory or even just routine elective coverage?
Well, level 4 becomes absolutely critical in hypopharynx or lower pharyngeal disease, and certainly in advanced nodal disease, think bulky N2 or N3 in levels 2 and 3. The probability of spread, even skip metastasis, increases significantly once the upper basins are heavily involved.
What about for our T2N1 tonsil case? We included it in the board script.
For a T2N1 tonsil case like ours, level 4 is almost always included electively, even if the PET CT is clean below the cricoid. And here's why. The presence of an involved level 2 node means that the first echelon is overwhelmed.
Okay.
That increases the likelihood that microscopic disease has already jumped down to the next drainage station. Omitting level 4 in an N1 neck is, I think, an unnecessary risk based on consensus and historical failure patterns.
So we treat the probability. Got it. And now we swing posterior to level 5, the posterior triangle. This is often called the shoulder toxicity level, and for good reason.
A very accurate and necessary nickname. Level 5 is the region posterior to the SCM and anterior to the trapezius muscle. It's typically subdivided by the cricoid level into an upper part, 5A, and a lower part, 5B.
And what are the primary associations for level 5? What specific primaries earn its inclusion, and what does sparing it achieve?
It's strongly tied to nasopharynx, as that disease often spreads posteriorly, and also to posterior drainage from the scalp, skin, and thyroid. If level 5 is involved, it usually signals either primary posterior disease or very heavy, diffuse nodal burden spanning the entire neck.
And the toxicity. Be specific about the shoulder.
So the reason for the nickname is that level 5 coverage frequently delivers unavoidable dose to the spinal accessory nerve and the musculature it supplies, specifically the sternocleidomastoid and the trapezius. Damage here results in classic delayed shoulder dysfunction, weakness, fatigue, inability to abduct the arm past 90 degrees, often referred to as shoulder droop syndrome. This is a severe late morbidity. If you don't need level 5 for an oropharynx primary, keeping that dose off the posterior neck is essential patient advocacy.
We've covered the lateral and posterior neck. Finally, before we hit the deep central spaces, we have level 6, the central compartment.
This is the anterior central neck. So the prelaryngeal, pretracheal, paratracheal, or recurrent laryngeal region. It's situated centrally, between the carotids, extending high centrally down toward the sternal notch.
What is the high-yield association for level 6?
Thyroid cancer. Also glottic or subglottic patterns with subglottic extension, postcricoid or cervical esophagus, and any anterior midline drainage like certain advanced floor of mouth lesions. The keyboard takeaway here. Level 6 is not a routine elective level for oropharyngeal cancer, including our tonsil case.
And if we include level 6 unnecessarily, what are the primary OARs we are contaminating?
You contaminate the larynx itself, increasing the risk of laryngeal edema and chronic voice changes, and the upper esophagus, which increases the risk of chronic stricture and swallowing impairment. It's a high-stakes anterior region that you have to spare unless the anatomical spread of the primary truly demands coverage.
That completes the standard grid, but we can't stop there.
No, absolutely not. We have to cover the don't miss these spaces. These are the nodes that are often deep, small, and completely invisible on a routine head and neck exam, but they are crucial drainage pathways. Missing them is a guaranteed cause of recurrence on board exams and in real life.
I think I know where you're going. You're talking about the retropharyngeal nodes, sometimes labeled level 7A, and they are the classic silent miss zone?
They are silent because they're deep against the spine and they are not palpable.
Okay.
So where exactly do they live on the CT scan? They reside in the retropharyngeal space. This space is bounded anteriorly by the pharyngeal constrictor muscles and posteriorly by the longus colli muscles, which sit right against the C-spine.
And the key lateral boundary.
The medial edge of the internal carotid artery region. So if you're drawing your contour and you cross medially past the carotid, you are deep in the retropharyngeal space.
And vertically, they're quite high, aren't they?
Yes, very high. Running from the upper C1 region or hard palate level down toward the level of the hyoid. They're a primary landing zone for the posterior pharyngeal wall, the nasopharynx, and certain highly aggressive upper or pharyngeal disease.
So when do we absolutely need the retropharyngeals? When is the risk too great to spare them?
High-yield rule. They are essential in nasopharyngeal carcinoma, or NPC, because the lymphatics drain directly posterior. They also matter in posterior pharyngeal wall cancers, the soft palate, and selected oropharynx subsites, especially tonsil cases with documented posterior extension or significant nodal burden.
So if the disease hugs the back wall, you have to include them.
You must include the ipsilateral retropharyngeals.
And what about the less common but equally important retrostyloid nodes?
Right, often labeled level 7B. These are just the cranial continuation of the upper jugular chain, moving superiorly toward the skull base and the jugular foramen region. They are highly relevant, again, for NPC and any disease that is pushing right up to the skull base, often involving the superior aspects of level 2. They represent the lymphatic transition into the deep parapharyngeal space.
That gives us the map. Now let's quickly solidify the pathology and staging context that placed our patient in that favorable stage 1 category. The fact that he's T2N1, but stage 1, that hinges entirely on the pathology.
Correct. We're using the AJCC 8th edition staging system, which dramatically changed how we approach HPV-positive disease. Our case is a clinical T2, clinical N1, M0 right tonsil SCC.
And that P16 positivity, indicating the HPV association, is the great discriminator.
It is.
The HPV-positive classification moves this otherwise stage 3 T2N1 case into the favorable stage 1 category. And that just reflects its typically improved prognosis and higher sensitivity to radiation.
Right. And while the overall prognosis is better, we must always check the pathology report for those critical high-risk features that might immediately escalate management or volume definitions, even in stage 1.
We talk about extranodal extension, or ENE, all the time. Can you break down the difference between microscopic and gross ENE and why that distinction matters for our current case?
That's a critical nuance. So gross ENE is what you see on imaging. The node looks messy, spiculated, or it has clearly breached the capsule and infiltrated the surrounding soft tissue or muscles.
Okay.
Microscopic ENE is only visible under the microscope after a surgical resection. In the definitive radiation setting, we're primarily concerned with the gross, imaging-defined ENE or signs that suggest it, like massive or fixed nodes.
And how does the presence of ENE specifically impact the management of a favorable stage 1 T2N1 patient?
It acts as an immediate alarm bell. The moment ENE is documented, especially gross ENE, the risk of recurrence increases significantly. So even though the patient is technically stage 1, the presence of ENE usually triggers the need for concurrent systemic therapy.
So, adding chemo.
Typically cisplatin, to control the microscopic disease spread that has occurred beyond the node's capsule. While some de-escalation trials are looking at sparing chemo in low-risk stage I, ENE is often the feature that pushes us back to a combined modality approach.
And beyond ENE, we also look for perineural invasion, PNI, and lymphovascular invasion, LVI. Why are these important?
Well, PNI indicates that the tumor is spreading along nerve tracts, which can necessitate expanding our PTVs to cover that specific nerve pathway, often leading up to the skull base, a subject for our next discussion. And LVI shows us the tumor has access to the bloodstream and lymphatics, suggesting a higher metastatic potential. These features just increase the risk profile and support the decision to include broader elective volumes like level 4 or potentially intensify systemic therapy.
And just to close the loop on workup, We stress the need for comprehensive imaging.
Right, high-quality cross-sectional imaging of the neck with contrast, often CT or MRI, if we have concerns about PNI, or soft tissue delineation near the skull base. And this has to be followed by the essential PET-CT.
Why both?
Well, the PET-CT rules out distant metastatic disease, confirms the metabolic activity of the primary and the nodes, and is crucial for confirming that the uninvolved neck, the areas we plan to treat electively, are truly N0.
With the anatomy and staging established, let's move into the heart of the decision-making process, the clean risk ladder. This is that board-safe mental framework for site-specific elective coverage.
This framework is what allows you to confidently explain your volume decision to an examiner. It's all about matching the predictable failure patterns, those codified highways, to the primary site.
Okay, so let's start with the one that causes the most debate in terms of volume expansion. Nasopharynx or NPC?
NPC is an anatomical anomaly. It often spreads superiorly and posteriorly first. If you see NPC, your default elective coverage is bilateral levels 2, 3, and 5A. And you must include bilateral retropharyngeal nodes.
Can't forget those.
Missing the retropharyngeals is the ultimate board trap for NPC because that is often the very first site of spread.
Next, oral cavity. Let's focus on a high-risk anterior primary like oral tongue or floor of mouth.
So oral cavity disease typically goes high and anterior first, using the submental and submandibular basins. So the coverage default includes levels 1A, 1B, 2, and 3.
But it's tailored.
Always tailored. For instance, a very small lateralized T1 tongue might allow us to spare 1A, but you always need to justify your omission based on subsite, depth of invasion, and the clinical extent.
And our current case falls under oropharynx, the tonsil. What's the standard ladder here?
For a tonsil case, the default is ipsilateral levels 2 and 3, and crucially, often extending to 4. Laterality is key. If the primary is well lateralized, we usually stay ipsilateral. If the mass approaches the midline, or if there's soft palate or base of tongue extension across the midline, we must consider treating the contralateral neck.
At least to an elective dose.
At least levels 2 and 3 to the elective dose, absolutely.
Finally, larynx and hyperpharynx. Where do they drain?
These primaries drain primarily down the jugular chain, so we focus on levels 2, 3, and 4. Hypopharynx disease is notorious for high rates of level 4 involvement.
Okay.
The key decision point is level 6, the central compartment. We only consider level 6 coverage if the disease pattern warrants it. Think subglottic extension, transglottic disease, or postcricoid or cervical esophageal involvement.
So for a pure supraglottic cancer?
For a pure supraglottic cancer, you can often spare level 1B entirely, but you must cover levels 2, 3, and 4 aggressively.
Let's apply this ladder back to our patient. A T2N1P16 positive tonsil, which was reported as well lateralized on exam and scope, with a single right-sided level 2 node.
The goal is definitive radiation therapy. So we are covering the gross disease, the primary right tonsil, and the involved right level 2 node with appropriate margins.
Now, for the elective coverage of the uninvolved neck, we start with the predictable spread.
Right. We electively cover the ipsilateral level 2 and level 3. Level 2 is included as the primary basin, and level 3 is the inevitable next step down. Now, the debate is level 4 and the retropharyngeals.
Okay, I'm the listener advocate here. If the PET-CT below the cricoid is clean, why hit level 4 and potentially increase dose to the lower larynx and upper esophagus, which increases the risk of chronic aspiration and dysphagia? Isn't that where we can afford to be more aggressive with toxicity sparing in a stage 1 patient?
That is the perfect question, and it separates good treatment from great treatment. While the PET-CT is excellent, it has a detection limit, especially for microscopic disease. Historical data and consensus guidelines show that once level 2 and 3 are involved, so N1 or greater, the risk of microscopic involvement in level 4 is meaningful, often cited in the 10 to 20% range for oropharynx.
So it's a numbers game.
It's a numbers game, and since this is curative intent, we err on the side of controlling that probability. If the patient had a small T1N0 primary, we might debate level 4. But the presence of an involved node, N1, means the lymphatic system is stressed. Therefore, level 4 inclusion is the standard of care for definitive treatment in N1 oropharynx, even P16 positive. We control the high probability highway.
Understood. We treat level 4 as an essential step down in the presence of existing nodal burden. What about those retropharyngeals, the silent miss zones?
In our specific T2N1 tonsil case, we should selectively include the ipsilateral lateral retropharyngeal nodes only when the risk is meaningfully increased. Since our exam noted the mass was confined to the tonsil or fossa without obvious posterior wall involvement, the risk is lower.
So what would meaningfully increase that risk and mandate inclusion?
Documented posterior pharyngeal wall involvement, soft palate involvement, or base of tongue extension that pushes toward the midline. If the primary tumor were bulkier or positioned posteriorly, the RP nodes would be mandatory.
But in a truly well-lateralized, low-risk tonsil case like this.
Some practitioners might omit them, but you must justify why, citing the lack of posterior involvement on scope and imaging.
The intentional omission segment is just as crucial as inclusion. This is where we demonstrate we're actively prioritizing long-term quality of life.
This is a part of the plan that saves the patient from unnecessary toxicity. For our tonsil case, based on the anatomical drainage, there are 3 primary intentional omissions.
First, we omit level 1B.
Because level 1B is the oral cavity level until proven otherwise. A tonsil primary does not routinely drain there. We omit level 1B to spare the submandibular salivary gland region and prevent that sticky, thick saliva issue.
Second, we omit level 5.
In a low-risk, well-lateralized early tonsil pattern, level 5 is not a primary drainage route, so we omit level 5 to reduce dose to the posterior neck, thus reducing the risk of spinal accessory nerve injury and shoulder region toxicity.
And finally, we omit level 6.
Level 6, the central compartment, is not routine for tonsil. If you include level 6 unnecessarily, you are sacrificing esophageal and laryngeal dose sparing for zero oncologic benefit. We reserve level 6 for disease patterns that drain anteriorly or inferiorly, like subglottic extension or thyroid involvement.
The decision to include or exclude a level fundamentally dictates the success of external beam planning. So let's talk techniques generally, focusing on target volumes.
Yes. For external beam planning, we always define our targets in 3 stages: gross tumor volume, clinical target volume, and planning target volume.
GTV covers the obvious disease, the primary tumor, and the involved nodes we identified on CT and PET-CT.
And the CTV is where this whole anatomy lecture pays off. The clinical target volume is the GTV plus margins for microscopic disease, and crucially, it includes our elective nodal volumes. This CTV must encompass the entire anatomical risk basin levels 2, 3, and 4 in our case, with precise boundaries that respect the muscle and fascial planes that define those levels.
So if your level 3 contour doesn't run from the caudal hyoid down to the caudal cricoid,
Your CTV is geometrically inadequate. It's as simple as that.
and then we apply the planning target volume, or PTV, margins around the CTV to account for daily patient setup error, motion, breathing variability. The anatomical logic has to be flawless in the CTV stage, because if that volume is wrong, the PTV is flawed and geometric failure is inevitable.
And regarding dose and fractionation for definitive management, the gross disease and involved nodes typically receive a high curative dose, usually in the range of 66 to 70 gray.
And the elective dose.
The elective nodal dose, delivered to the uninvolved at-risk necks, so levels 3 and 4, is a lower dose, typically in the range of 50 to 54 gray, delivered concurrently.
Why the lower elective dose?
Because the goal of the elective dose is to eradicate microscopic disease, which is presumed to be less resistant than the gross tumor volume. Giving 50 gray to the at-risk basins provides excellent control, while minimizing long-term normal tissue damage in those regions. This is really the foundation of the dose painting technique. This brings us back to our critical toxicity management anchor, xerostomia. While radiation damages the parotid glands, leading to the watery saliva loss, the day-to-day patient misery, the thick, sticky saliva, the constant dryness, the difficulty clearing food, that is very strongly shaped by how much unnecessary dose you deliver to the submandibular region and adjacent oral cavity structures.
So the patient may have water, but they can't manage thick foods or speech.
Exactly. We often constrain the mean dose to at least one parotid gland to 20 to 26 gray to try and preserve function. But the submandibular gland, located in level 1B, is often completely sacrificed in oral cavity cases. Since our tonsil case doesn't require level 1B, sparing that submandibular dose is a major win for the patient's mucus production.
So the simple, practical prevention move.
Do not include level 1B when it is not at risk. If you're treating an oropharynx or larynx primary, justify your CTV with clear anatomical boundaries, specifically the digastric muscle, to avoid unnecessary anterior oral cavity coverage. This is one of the cleanest, most predictable ways to reduce avoidable, life-altering xerostomia.
Now that we have detailed the anatomy and the rationale behind the planning decisions, let's move into our dedicated board review segment, starting with the 3 critical oral board traps, the mistakes that advertise a dangerous blind spot to the examiner.
Okay, trap 1. Nasopharynx without retropharyngeals. If you get an NPC case and you list neck levels but forget to explicitly mention bilateral retropharyngeals, the examiner knows immediately that you have a fundamental gap in NPC drainage patterns. Remember, that is the silent miss zone.
Trap 2 is the toxicity trap we just spent so much time discussing, casually saying level 1 through 4 for a larynx or hypopharynx case.
Right, a supraglottic cancer does not drain to the submandibular region. Saying, I'll treat level 1 without purposefully omitting 1B shows a failure to tailor the volume, leading directly to unnecessary salivary toxicity. It shows a lack of anatomical precision and respect for quality of life.
And trap 3 relates to undertreating the lower neck, especially in advanced disease.
Specifically in hypopharynx or bulky lower pharyngeal patterns. These diseases have a high propensity to spread into the lower jugular chain and supraclavicular region. Stopping too high, perhaps at level 3 because you're still mentally mapping an early consult case, is a classic miss that leads to geometric failure in the low neck. Always treat level 4 in advanced disease below the hyoid.
These traps teach us the logic. So let's distill that logic into our clinical pearls. The high-yield takeaways you should carry with you.
Pearl number 1. Levels are failure patterns codified. You are not just drawing boxes, you are treating probability highways. If the probability of spread is high, you include the level. If it's negligible, you spare the patient the toxicity.
I think that framework moves you from just rote memorization to genuine evidence-based understanding.
Pearl number 2. The retropharyngeal rule. Retropharyngeals are absolutely essential in NPC, and they are a known risk region in posterior pharyngeal wall and specific oropharynx patterns. Never ignore the posterior spread.
Pearl number 3, the level 1B rule.
Level 1B is the oral cavity level until proven otherwise. If the primary is not oral cavity, think twice before including it to protect salivary function, specifically that lubricating mucus component.
Pearl number 4, the level 6 rule.
Central compartment level 6 is not a default tonsil volume or even a default hypopharynx volume. Do not contaminate the anterior neck with dose unless the disease spread, like subglottic extension or thyroid involvement, truly demands coverage.
And finally, pearl number 5, the 2B decision.
Sparing level 2B must be a purposeful, high-risk decision, supported by a very favorable N0 well-lateralized risk pattern. If the patient has any nodal burden, or if the primary is high-risk like NPC, level 2B must be included to control disease spread along the spinal accessory nerve path.
These pearls are designed to keep you safe and efficient by ensuring you match the treatment volume to the tumor's drainage logic. Now let's wrap up with our board blitz, a few quick questions to solidify your grasp of these anatomical rules.
Let's do it.
Question 1. A patient has nasopharyngeal carcinoma. Which nodal region must be electively covered but is commonly omitted in a truly well-lateralized, low-risk tonsil case? Is it A, level 2, B, level 3, C, retropharyngeal nodes, or D, level 1B?
The best answer here is C, retropharyngeal nodes. They are non-negotiable for NPC due to its posterior drainage, but can often be safely omitted in a low-risk, well-lateralized tonsil case. The key is distinguishing the primary sites.
Question 2. You are planning adjuvant radiation therapy for a resected oral tongue cancer. Which nodal level is classically first echelon and must be addressed unless clearly uninvolved or low risk by subsite and pathology? Is it A, level 1AB, level 1BC, level 5, or D, level 6?
The best answer is B, level 1B. This is the definition of the oral cavity level and the primary landing zone for most oral tongue disease, meaning the submandibular region must be included.
Question 3. You are planning definitive radiation therapy for a supraglottic larynx cancer and realize you unnecessarily included the submandibular region in elective coverage. Which level did you most likely include without indication, thereby jeopardizing salivary function? A, level 2AB, level 3, C, level 1B, or D, level 4?
The answer is C, level 1B. Supraglottic cancer drains to the upper and middle jugular chains, 2 and 3, and does not typically utilize the submandibular route. Including level 1B is an anatomical mismatch that introduces avoidable toxicity.
That was a comprehensive tour of the foundational neck anatomy and its direct translation into clinical decision-making. We started with the T2N1P16 positive tonsil case and built the anatomical rationale for every single volume decision.
Yeah, we established that level 1B is the oral cavity level. Level 6 is not a default tonsil volume. Retropharyngeals are essential in MKC and posterior disease. And most importantly, we learned that we contour failure patterns based on predictability, not just random lines on a CT scan.
So we've built the anatomical map of the neck, but we are just getting started. The cancer doesn't always stay in the predictable lymphatic highways. Sometimes it travels along the nerve cables.
That is exactly right. In the next session, we start driving the car and expanding our target volumes when the disease becomes sneaky and utilizes neural pathways. The discussion will cover skull base and cranial nerve pathways, specifically how paraneural invasion, or PNI, changes volumes. We'll detail which specific foramina the anatomical gates are absolutely oral board critical when evaluating disease extent and determining necessary dose escalation.
Complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.